Hi, everybody. I'm Vamshi Rao. I'm a pediatric neurologist at the Ann and Robert H. Lurie Children's Hospital of Chicago, and I'm very pleased that I'm joined by Dr. Nancy Coons. Dr. Coons,
Hello. It's wonderful to have a chance to talk about this with one of my favorite neuromuscular specialists.
uh, Dr. Coons, you are also at the Ann and Robert H. Lurie Children's Hospital of Chicago, and we are colleagues. So I wanted to ask you about some of the complications that you see in Duchenne muscular dystrophy. As we see kids together, what early signs do you think clinicians should be looking for when you are assessing children with DMD?
Well, it primarily comes down to the issue of muscle weakness, but we don't always think of muscle weakness as in its long-term consequence. For example, it's just something as simple as breathing. We take breathing for granted and are always thinking about air exchange and oxygenation and carbon dioxide and things like that. But the respiratory muscles are critical at ventilation. So it's not so much the oxygenation, but really the mechanics of bringing the volume and the pressure of air into the body and into the lungs so that all the rest of those physiologic things can happen. Um, and respiratory weakness is certainly an important and a long-term consequence of muscular dystrophy. It usually is relatively silent, beginning just causing some hypoventilation during sleep. All of us breathe somewhat more shallowly during sleep, and so individuals who have respiratory muscle weakness have a little bit of relative failure to clear their carbon dioxide when they sleep, and therefore wake in the morning with a little bit of elevated carbon dioxide levels, and it presents with a little bit of a headache, a little bit of fuzzy morning, and as a parent myself, I know that there are some children who are just not morning people, so that can be a very, very subtle sign. Thankfully, this usually doesn't occur before the diagnosis of Duchenne muscular dystrophy has already been made, but that's one of the things that should be carefully considered as an important consequence and complication of weakness in muscular dystrophy. Then there's things that happen to bones and joints. Uh, and again, bones and joints aren't necessarily the first thing that you think about when you are considering muscle weakness in an individual. Toe walking is an interesting issue, and it's really related to tightness around the ankle joint. All of us have an imbalance between the anterior compartment and calf or posterior compartment muscles in the lower leg, but this is more uh, different, more discrepant in individuals with dystrophinopathies. And it's not uncommon either as a presenting factor when they first start walking or as something that develops over time to have toe walking. And again, toe walking takes more energy, is less stable, and with the proximal weakness that's also present, predisposes toward falls. And so this is something that has to be watched for and tried and prevented as much as possible in muscular dystrophy. And then finally, the trunk muscles, again, are proximal and tend to be quite weak, and therefore either hip problems and or spinal column problems due to inadequate support from the surrounding muscles can lead to deformities, either the hip slipping out of position or out of socket, or the spine having a tendency to curve when the patient's upright in an upright position. And both of those can lead to additional energy expenditure with movement or posture, maintaining posture or attempting to walk, or create other problems. For example, if a lot of scoliosis develops, then the bellows of the lungs that the ribs create to allow ventilation becomes inefficient because of the mechanical torque put on by the curved spine. And that's another problem that can develop. Where the root cause really all goes back to muscle weakness. The muscle weakness, again, begins relatively subtly and in only certain muscle groups. The neck flexors tend to be the ones that can be detected by a very inquisitive examiner in the newborn period. If you take a child and slide them along the examining table until they're at the point where the shoulders are supported, but the head is no longer supported except by your hand, most healthy term newborns will crane forward to keep the head from falling. But boys with dystrophinopathies, in the few times I've had the chance to examine them as a newborn, struggle to keep even rather than craning forward. But that obviously worsens over time, and so it goes from just the neck flexors to trunk and proximal muscles and then diffusely. Um, and again, it's not just weakness, but unlike some static myopathies, there is secondary inflammation due to the leakage of the intramuscular contents, and that actually causes muscle breakdown and loss of muscle tissue. So atrophy ensues as well. What are your approaches, Dr. Rao, in terms of trying to prevent long-term problems, knowing that this is all going on in individuals with Duchenne?
Yeah, I think one of the things that we sometimes forget as we look at progression of the disease and complications therein is that the heart is a muscle. And the heart over time also progressively uh, weakens. And some of the signs and symptoms that you could notice from that weakening are signs and symptoms of frank heart failure at the very end, but beginning with just a reduced ability for the heart to do what it's supposed to do, which is pump blood to the rest of the organs. And that can manifest in terms of symptoms such as shortness of breath, dizziness, palpitations, or even headaches. Um, and I think, as you alluded to, with the skeletal muscles being weak, there are lots of secondary sort of complications that come forth. In Duchenne, unfortunately, there's a sort of double whammy, so to speak, with skeletal muscles being weak, causing bones to be weaker, but at the same time having had steroids on board that is absolutely needed as standard of care. Both those two sort of things cause bones to further weaken and increase fracture risk. Sometimes long bone fractures unfortunately can lead to fat embolization, and that can really be a very dangerous sort of complication of that. Um, Something that we have to be better at over time is the whole aspect of Duchenne as a disease causing mental health issues in terms of adjustment, but Duchenne as a disease primarily causing uh, a autism spectrum and an ADHD like phenotype. And I think sometimes that goes unrecognized because the H component of ADHD is hyperactivity, and the scale really doesn't do justice to children who actually cannot be hyperactive, and so there's a confounding, in there. So having a high index of suspicion in terms of social interactions and delayed speech can clue us in on ADHD and an autism spectrum like phenotype, and really help with instituting mental health support. Um, one of the really important things that you and I in clinic often do as we first diagnose a child is to make sure that we let parents be very aware that certain anesthetics can cause malignant hyperthermia and cause issues with being able to be extubated due to underlying muscle weakness, and that families should make their anesthesiologists or proceduralists or surgeons aware of the fact that they have been diagnosed with Duchenne muscular dystrophy.